Good morning, everyone. I warmly welcome you to the Young Physicians Forum and the college lecture for the month of October of the Ceylon College of Physicians. Today, we'll be having again two Young Physician Forum presentations, which is supported by, as usual, Cipla Pharmaceuticals, and the college lecture is supported by the Sidus Sunshine. To start off our first lecture, it's my pleasure to invite Dr. Ruchira Chintaka Palyaguruge, Senior Registrar in Neurology, National Hospital, Kandy. He'll be talking to us on management of refractory and super refractory status epilepticus. Over to you, Ruchira.
Thank you very much for the kind introduction, Gilzer. And it's always a great pleasure and a privilege to perform in this prestigious forum. And thank you very much, Ceylon College of Physicians, for taking all the trouble in arranging us this platform. I'm Ruchira Palyaguruge, Senior Registrar in Neurology. And today I'm going to talk about, since the World Cup is going on and it is on, how to play the power play and the superpowers, the management of refractory and super refractory status epilepticus. This cuneiform tablet was buried under the valleys of Euphrates for ages. It was found by the archaeologists and later on stolen by the neurologist. In an interesting article published in the British Journal of History of Medicine, it is mentioned that the ancient Babylonians were keen observers of clinical medicine. They knew that the stroke is unilateral, and they knew and they drew the beautiful pictures of wild beasts who've been paraplegic following back injury. Not only that, they have nicely written here, persistent seizures will end up in death. It may go on for some time, but he will die. So that is 3,000 years back. And now, in 2015, this is a review article published in Journal of Epilepsy and Behavior. Why do patients die after status epilepticus? Ladies and gentlemen, unfortunately, 3,000 years later, after a lot of advancement in clinical medicine, still, I have to talk about a higher mortality in status epilepticus, especially in the refractory and super refractory forms. And then I would like to focus on this favorite theme, holistic care amidst constraints, Ceylon College of Physicians theme for this year. Ladies and gentlemen, despite of this being a devastating condition, a challenging condition, a proper clinical sense, good clinical sense, good pharmacovigilance, as well as prompt treatment can reduce the damage of this devastating condition. That's why I have selected today's topic. And let me outline. I'll start with a challenging case scenario that I have encountered, and I will define the basic terms, classification, epidemiology, investigations, and pathophysiology I will go through, and brief introduction about nuanced refractory status epilepticus and febrile infection-related epilepsy syndrome. And I would like to emphasize on management principles and some pharmacological, non-pharmacological management, as well as imaging therapy. And I would again like to emphasize on where we can go wrong, the pitfalls. Let me introduce 30-year-old primary, period of amenorrhea of 6 weeks, who recently had flu-like symptoms 1 week back, presented to the emergency department with severe vomiting for 4 days duration with order level of consciousness. And at the ETU, she had 1 episode of left-sided focal convulsion with impaired awareness. GCS was 14. Rest of the neurological examination was unremarkable. She didn't have signs of meningism or other features of infection. And investigations revealed hyponatremia, which was gradually corrected, and she was treated empirically as per Wernicke's encephalopathy as well with IV thiamine. And on the next day, GCS dropped and she had continuous seizures with the semiology of figure of 4 pattern. So this is an important lateralizing sign where one arm is kept extended at the elbow and one arm is kept flexed at the elbow, resembling the number 4. And patient is seizing like that, and in 92, literature says that in 92% of occasions, the epileptogenic foci is contralateral to the side of the extended arm. And then later on, it progressed to bilateral tonic-clonic convulsions with impaired awareness and into status epilepticus. We escalated treatment with midazolam, phenytoin, levetiracetam, and midazolam infusion, but was not successful. and patient was admitted to the ICU with the midazolam infusion. But after taking of midazolam infusion, there were non-motor features, but this is for the drop. In this clinical setting, we suspected the possibility of non-convulsive status epilepticus, and urgent EEG revealed periodic lateralized epileptiform discharges. So the proper diagnosis of non-convulsive status epilepticus was confirmed with the spatiotemporal evolution, and treatment escalated with IV fentanyl, and she was ventilated for neuroprotection, and we managed aiming burst suppression. And since the clinical features of focality, we started empirical on IV cyclovir as well. And after 72 hours, there was no clinical improvement, and patient clinical deteriorated. And at that point, with the given febrile illness, history of febrile illness 1 week back, we suspected the possibility of febrile infection-related epilepsy syndrome files. And due to the postulated immune-mediated mechanism, we started on immune therapy with imidacloprid, followed by 5 cycles of plasma exchange, and she was covered with antibiotic during that period, even though there was no obvious features of infection. And patient actually improved clinically, and GCS improved, but there was disability left. And these were the investigations: electrolytes, CSF was clear, and inflammatory markers, cultures were clear. Imagine MRI brain revealed some T2 hyperintensities, especially in the thalamic area, which could be possibly due to the seizures itself. EEG revealed periodic lateral epileptiform discharges, and we were able to achieve a burst suppression. And since the patient had improvement, but there was retained disability, after 7 days, we were planning to start on IV rituximab. But unfortunate incident happened, and patient had an aberrant esophageal artery, and from which she bled profusely, and massive transfusion, endovascular treatment, as well as open surgery done, but could not salvage her, and she succumbed. But she left a lot of messages to reflect, a lot of messages to learn. That's why I have selected her scenario today. The definition of status epilepticus, International League Against Epilepsy, in 2015 defined status epilepticus as a condition resulting either from the failure of mechanisms responsible for seizure termination or from the initiation of mechanisms which lead to abnormally prolonged seizures, which can have long-term consequences after 9.2, including neuronal death, neuronal injury, and alteration of neuronal network depending on the type as well as the duration of seizures. Time is brain. This was originally coined in terms of hyperacute stroke, but it is very well applicable to this condition as well. Here we are discussing about 2 time points, time point 1 and time point 2. Time point 1 is the time point where the seizures are unlikely to abort spontaneously, so that you have to start treatment. It is 5 minutes for bilateral tonic-clonic seizures, and usually 10 minutes for focal status epilepticus. And time point T2 is the time point where whatever the treatment you have started should be successful by now. It's an alarming time point, because after that, irreversible brain damage is going to happen. So that is 30 minutes for bilateral tonic-clonic convulsions, and for focal convulsions is 60 minutes. So it's clear that we have to intervene between T1 and T2. So what is refractory status epilepticus? I would define the terms. Its status epilepticus persisting despite administration of at least 2 appropriately selected and dosed parenteral medications, including benzodiazepines. Here, no specific duration is mentioned. What is super-refractory status epilepticus is the next stage where the patient is having persistent seizures at least after at least 24 hours from the onset of anesthesia, or else the seizures recurs when we are weaning off anesthesia. Since I mentioned about non-convulsive status epilepticus, I will brief about Salzburg criteria. Where this is an important condition where we have to suspect in patients with status epilepticus, especially in the ICU setting, even though there are no motor features, if the patient is clinically deteriorating, as registrars and senior registrars in medicine as well as neurology, trainees in neurology, and all of us should suspect this condition, which is treatable. So when there are classic epileptiform discharges with high frequency more than 2.5 Hz, we can straight away diagnose. And even without 2.5 Hz, if there's prompt response after anti-seizure medication, and if there's typical spatiotemporal evolution and persistent subtle clinical ictal phenomenon, in that case also, we can diagnose non-convulsive status epilepticus. This is the beautiful city of Salzburg in Austria, and Professor Eugene Tricka, who made a tremendous contribution in this updates in management of refractory status epilepticus. When it comes to epidemiology, this is up to 43% of patients with status epilepticus will progress into refractory status epilepticus, and out of them, 1 150 progressive to supra-refractory status epilepticus. As I have repeated, this condition has a higher mortality, up to 40%. And mortality is largely dependent on patient's age as well as the etiology. And etiology can be infective, infections, and as well as intoxications, especially in acute symptomatic seizures, which carries higher mortality, and patients in elderly patients has higher mortality. And outcome is not good always, and they are less likely to return to baseline, longer hospital stays, and more likely to require inpatient rehabilitation, and survivors are more likely to develop long-term epilepsy. I will brief about the pathophysiology. This is a condition like a battle between two teams, team excitatory as well as team inhibitory. Team excitatory is governed by the weapons of GABA receptors. Team inhibitory is governed by the GABA, and team excitatory is mainly governed by the glutamate. But as the time battle goes on, the weapons of GABA kept locked and their receptors are internalized, so their firing ability is more and more weakened. But the weapons are oversupplied for the team excitatory, team glutamate, and so they are firing continuously, and which is sustained by receptor trafficking, neuropeptide expression, and which is maintained by genetic expression. So, what is the take-home message from this pathophysiology? So, we know the monotherapy is the norm of epilepsy, but it is not applicable to this stage. At this stage, either you have to select drugs with multimodal action, or else you have to select a constellation of medications with different mode of action and acting on different receptors. What is new-onset refractory status epilepticus, and what is febrile infection-related epilepsy syndrome? These are newly coined terms, and NOS is diagnosed 72 hours after the onset of epilepsy, onset of seizures in patients without prior epilepsy and without pre-existing relevant neurological disorders and without acute or active structural, metabolic or toxic cause. And FIRES is classified as a subcategory of a new-onset refractory status epilepticus. In 2018, international group of 18 experts from 8 countries developed case definition for these terms, and it requires febrile infection between 24 hours to 2 weeks prior to the onset of refractory status epilepticus, but fever may not be always present. It is mostly, there's no age restriction for FIRES, but mostly seen on young school-age children. But the most important thing is, in most of these patients, it was found that pro-inflammatory cytokines and chemokines has been elevated in serum and CSF of these children, which supports the postulated immune-mediated mechanism. Basic investigations I would rush through. EEG, MRI, CSF would be very helpful. So at least imaging would be in a resource poor setting, at least a CT or contra-CT would be beneficial. And as well as parallel, we have to look for infective causes, inflammatory markers, metabolic causes, as well as autoimmune causes we have to actively look into. MRI, we have to carefully interpret in this setting, because some of the MRI changes are likely to be due to the effect of the status epilepticus rather than the cause of the status epilepticus. That should be kept in the back of the mind. And therefore, there can be a lot of MRI changes can occur. Hippocampus, amygdala, insula, claustrum, thalamus, pericyclium, operculum, and basal ganglia changes can occur. So they have to be carefully interpreted, preferably with liaise with a neuroradiologist. EEG is pivotal. Continuous EEG is very helpful in a resource available setting, and because up to 90% of seizures are clinically undetectable in refractory status epilepticus. Goal is to achieve burst suppression, which gives a valuable platform to start other anti-seizure medications and escalate them up to a therapeutic level, and then they can be gradually tailed off. So burst suppression is pivotal, and meta-analysis showed 4% likely to do a recurrence of seizures in the setting of burst suppression compared with 53% with just electroclinical suppression. So this is an example of burst suppression. How do you manage? How do you approach? Be the sensible firefighter. Imagine there's a fire burst at this spot. How are you going to manage this as a firefighter? You have to control the ongoing fire with whatever the available resources. If it is water, you have to start with water, and if it is carbon dioxide, then you have to go for carbon dioxide. But here you have to look for the underlying cause. If it is a gas leakage, you have to stop it. You have to, and you always have to sometimes act on the presumed mechanisms. most likely inflammatory and immune-mediated mechanisms, especially in the setting of new onset refractory status epilepticus. And you have to take the patients to the hospitals, the 5 victims, treat the complications, not only the patients, the fire affects the family also. So you have to go out of the corridors of the ICU and talk to the patient's family also. And this is a devastating condition with disability, so rehabilitation is also part of the management. Early status epilepticus has robust evidence, class 1 evidence, lorazepam, diazepam, midazolam. Midazolam comes in different forms, IV, IM, and intranasal and intrabuccal also has emerging evidence. And rampant study, which is a game changer, has given a very good sound evidence for IM midazolam. And in the lot of other countries, this approach with intramuscular midazolam, which can be given in the pre-hospital setting, has changed the game. But still, we are lagging with that. We have not used intramuscular midazolam in the pre-hospital setting. I think this is open for the discussion. It should come into practice one day. So, because IV midazolam in the rampant study was non-inferior or superior to IV lorazepam, and equally efficacious in children, and treatment with midazolam has associated with fewer hospitalizations, fewer ICU admissions, short ICU stay, and hospital lengths were shortened. And these two pictures show intrabuccal and intranasal midazolam administration in a child, which are emerging. Repeating the dose, expert opinion, may be repeated 10 minutes after the first dose. And this is also a very important study. EZ study, established status epilepticus treatment trial, which was a large randomized multi-center double-blinded trial where the levetiracetam, fosfoxytone, and valproate was compared. Earlier, the thought was levetiracetam has low side effect profile and better efficacy, but it was disproven here. And levetiracetam, fosfoxytone, valproate, all are second-line medications in status epilepticus, and all have equal efficacy and as well as equal side effect profile. And please do remember these doses: levetiracetam 60 mg per kg, phenytoin or phosphenytoin 50 to 20 mg per kg, and valproate 40 mg per kg. When you are hitting, you have to hit hard. There's no point in giving sub-therapeutic doses. The first dose should be higher dose. This is von Baer, who won the Nobel Prize for his tremendous work he has done in chemistry. And in one day, he was in a feast celebrating, artillery men were celebrating their Saint Barbara, and he was there, and he conceptualized his this idea about phenobarbital. This was one of the oldest medication, but all is gold. So it was discovered at the artillery men's event, and it is still firing after 150 years. Still, it is firing as one of the best available drugs in status epilepticus. So this is very important drug, even though large randomized double-blinded trials has not been done on this drug. Meta-analysis had shown it is superior to phenytoin, valproate, loperamide, and levetiracetam in terms of seizure cessation. So this is a low cost effective drug, and it is very important that we keep in mind about phenobarbital in a resource-poor setting. What are the available treatments for refractory status epilepticus and super refractory status epilepticus management? We have first-line anesthetic drugs, the second-line anesthetic drug, and other pharmacological medications, very importantly immune therapies and other non-pharmacological options like ketogenic diet, electroconvulsive therapy, epilepsy surgery, and stimulation therapy. First-line anesthetics: midazolam, propofol, and thiophanate. Midazolam, GABA agonist, which has a good CNS penetration for fast onset of action, and but we have to be cautious when giving midazolam, because after say 48 hours, it usually shows tachyphylaxis, and those might need to be escalated. Barbiturates, the GABA agonist, and they have had a neuroprotective effect, lowering the body temperature, and helpful in achieving burst suppression, but prolonged recovery due to longer T-half and high volume of distribution is problematic, and hypotension, acidosis, adynamic ileus add to the side effect profile. Propofol, GABA agonist, as well as NMDA inhibition also there. So it's a good drug with bimodal action, but it has rapid onset and low hemodynamic compromise. But if the patient passes green-colored urine while on propofol, you must be alarmed. This might be propofol infusion syndrome, which might be life-threatening. So avoid collateral damage while treating. Second-line anesthetics, ketamine is a wonderful drug which has it's a non-competitive antagonist of NMDA receptor, so it's act where the GABA receptors are internalized and render neuroprotection, and it does not cause much hemodynamic compromise. So wonderful drug. And I would like to draw your special attention to this article. This was the international consensus recommendation for management of new onset refractory status epilepticus, including febrile infection-related epilepsy syndrome. And this was published in 2022, August, in Journal of Epilepsy. So, in this setting, new onset refractory status epilepticus, after giving initial initial treatment with anti-seizure medication, first line, second line, after 72 hours, you must actively exclude an infection. And if it is excluded and still seizures persisting or patient is clinically deteriorating, you have to actively start on immune therapy. Do not hesitate to start immune therapy at this point if you are carefully ruled out an infection. So you can start with IV methylprednisolone 20 to 30 milligram per kilogram with a maximum dose of 1 milligram, and IVIG 2 gram per kg over 2 to 5 days. And therapeutic plasma exchange can be started meantime, but we know in the research setting there are some constraints, and at this point you can start ketogenic diet, which is a second line treatment. Especially it is proven in the children as well as in adults in refractory and super refractory status epilepticus. So after that, we can go ahead with third line therapy after 7 days. So in that case, the available drug for us is rituximab. Rituximab is well proven in the setting of antibody-mediated, antibody-proven setting, and they prefer in cryptogenic NOS and cryptogenic fires IL-6 and IL-1 inhibitors like tocilizumab and anakinra, but they are not readily available in our setting. So our survivor would be rituximab in prolonged super refractory status epilepticus. Here, IL-1 and IL-6 inhibitors usually not combined due to elevated risk of infection. Non-pharmacological therapy, ketogenic diet, therapeutic hypothermia, epilepsy surgery, and stimulation therapy. This is a beautiful film, cinematography, which was viewed around the story of two parents who are fighting hard to survive with their child. And at the end, they succeed with ketogenic diet. First, do no harm. It ring a bell. Yes, it is. It was a term which was coined by Hippocrates, the father of modern medicine. And he is the one who actually practiced this ketogenic diet as a remedy for epilepsy at the outset. And this has neuroprotection, which reduces the mitochondrial damage by the reactive oxygenation species, and usually it contains high-fat, low-carb diet with 4:1 ratio, and it induces ketone body production in the body, and there's no much hemodynamic instability and easy to start and administrate. So it's a wonderful drug, and which has proven treatment in large case series. Therapeutic hypothermia is a good adjuvant therapy, which is proven in hibernated class 2 study. So at the ICU setting, this can also be useful. Stimulation surgery, it's a bit tricky. It can be given if the epileptic foci is close to the cortical surface, but lower frequencies will lower down the seizure frequencies, but higher frequencies, more than 5 Hz, will escalate the seizures sometimes. So it has to be given with the expert opinion. Epilepsy surgery, helpful in refractory focal status epilepticus and resection of the epileptic zone, lobar or multilobar resections, and disconnection procedures like corpus callosotomy can be done. Emergent therapies, neurosteroids, they do allosteric modulation of the GABA receptors, so they act away from the GABA receptors. So even though GABA receptors are internalized, they can act. And allopregnanolone is an endogenous metabolite of progesterone, which has proven benefit. And ganaxolone, it's synthetic analog to allopregnanolone. And in an open label phase 2 trial, 92% of patients achieved seizure termination with ganaxolone. And cannabidiol, controversial drug, but it is very efficacious in terms of refractory status epilepticus because it has added neuroprotective properties according to with the anti-seizure medication properties. And it renders a good neuroprotection to the hypothalamus, especially with the acting on CBD receptors. Tocilizumab IL-6 inhibitors, which I discussed, is the third line immune therapy, which is quite beneficial in refractory setting. IL-6, IL-1 agonists anakin drug, especially favorable outcome in fires. Bevacizumab, new drug, analog of levetiracetam, high penetration of blood-brain barrier and rapid onset of action, and can be used in renal failure without dose modulation. So these are the newer therapies, but out of these, how many things are available in our setting? Handful. So what are the challenges in a resource poor setting? That's why holistic care is considered CCP valid here. We are a country with a large seizure burden because of treatment gaps are there and a lot of other compounding factors are there. So it's a country with a large seizure burden, and still we don't practice pre-hospital care. And knowledge and awareness among the patients as well as medical practitioners is doubtful, and it should be escalated. And availability of medication is always in a question. Technology, how many centers have continuous EEG monitoring? And geography, still we have a comparatively effective mechanism of referring to a tertiary care center, but what are the resources available in the tertiary care center to terminate these challenging, devastating clinical condition is always a problem. And on top of that, availability of literature and consensus guidelines. I think Sri Lanka League Against Epilepsy will be in future. We need a clear voice regarding this is how you should manage this status epilepticus. What are the pitfalls where we can go wrong? These are two beautiful pictures drawn by two medieval artists. Rafael Santiago on the left drew this young boy's picture, and it resembles true seizure. And Andrea Di Sardo drew this left side, right side picture, and it resembles a young woman who's having pseudo-seizure. So pseudo-seizures are often misdiagnosed. And 20% of, would you believe that? 20% of pseudo-seizures or psychedelic non-epileptic seizures end up in ICU setting, and they are being intubated and ventilated. So these are common in younger females for some other reason, but ideally diagnosed with video EEG. But if you can send a proper video clip to an expert, especially a neurologist, in 90% of accuracy, it can be diagnosed according to the literature. So if you're in doubt, always take a video and send to the neurologist. So these are the doubtful evidences. Eyes are kept closed, and head moves to side, and limbs are moving out of the face, and abnormal posturing like visceral posturing are there, and the evolution is fluctuating, and which is compounded by some other suggestibility, entrainment, and also these conditions would also be supportive for psychogenic non-epileptic seizures. And underdiagnosis and delayed diagnosis is a common challenge and common problem that lead to this devastating condition. Delayed treatment, it's always a problem. That one of the main problems that I'm highlighting again and again, because we must have a solution to this problem. We have this 1990 ambulance all over the country, so emergency pre-hospital care is available, but they need to be standardized. They're still doing only the basic life support. Apart from that, they're not doing much things, but if a proper training has been employed on them, then they can be utilized, because it is proven that if first dose of benzodiazepine is delayed by more than 1 hour, the resistance to benzodiazepines and all the other anti-seizure medication rise to 90%. There's no point in doing the drama after that. You have to do it at the outset, and this decision has to be taken. Meta-analysis found that even in the developed countries, up to 64% of patients does not receive a medication after 30 minutes, and only 50% of patients get pre-hospital care. In our setup, it is 0. And not treated the etiology. Do not hesitate, if at all, get the neurologist opinion and start on immune therapy in patients with new onset refractory status epilepticus. And in focal epilepsy, you can empirically start on acyclovir. And if you put the patient into ICU, regularly review and try to get rid of the ICU, and because try to get rid of the ventilation, start second line therapy. If you have started thiofental, cover with phenobarbital, which is less sedative, and try to get rid of thiofental and try to wean off the patient. And meantime, escalate the other non-sedative anti-seizure medications and do active surveillance for the complications, sepsis, thrombosis, and do not escalate the therapy for isolated EEG changes, which usually happens, and patients end up in longer hospital stays. Underdosing and titration is a problem. You have to hit hard. You always have to give the highest dose. If you're giving levotiracetam, give 60 milligram per kg at the first dose. And at the end of the day, this is what I have to say. This is the power play. So at least for the time being, play like Kusal Mendes. Kusal Mendes comes into the play early, and he doesn't wait until the ball spins, and he doesn't allow the bowlers to settle, at least in these days, and he hit hard. He made the power play with sixes. And also, he doesn't play the same shot to the every delivery, and he has a variety of shots. So multimodal action is appreciated. And he executes different plans for different opponents. If it is immune postulated mechanism, you have to hit with immune therapy. If it is infection-driven mechanisms, you have to treat the underlying infection. And therefore, with all these things, for the time being, he is the player who does the least damage to the team at the time point. Yet he is batting in a resource poor setting, so outcome is not always good. But still, you have to bat on. So be like Kusal Mendes in managing this power play and super overs. So at the end of the day, time is bread, act promptly. Refractory status epilepticus and super refractory status, these are emergencies, high mortality, and if not treated early, carries substantial risk of devastating complications. Misdiagnosis, not treated etiology, delayed diagnosis and treatment, and underdosing, and these are common pitfalls. Do not hesitate to start immune therapy in new onset refractory status epilepticus. If you are in doubt, get the neurologist's opinion, and also in fires. And if in suspicion of psychogenic status epilepticus, do not escalate therapy, do not start midazolam infusions, because before that, get a video clip and send to a neurologist. There are a lot of evidence-free zones out there, especially for an example. Phenobarbital is not tested in the EZ trial. And phosphenytoin was tested, but phenytoin was not tested in EZ trial. So we need more and more research too, which are particular to our area. Thank you very much. These are my references.
Thank you, Richard, for that presentation. And it's open for questions from the physical audience. Mike.
For that excellent presentation, comprehensive presentation. One question, actually, the other for me. You suggest is there one evidence to suggest one or the other? And you also mentioned diazepam directives, because I think we are in a risk-exposed setting. Probably the directives are much more cheaper than diazepam. It can be administered by untrained sort of paramedics. At this point of time, the issue with paramedics, the issue with sort of administering drugs is that they are not actually registered at the SMC as people who can actually administer drugs. And I think that is the biggest study because they don't have adequate training. I think there's some at least some of us are actually trying to rectify that by including that into a training program, which is I think by some of the universities, including Colombo. So you also made some that's been as a pre-hospital medication.
Yes, an excellent question, sir. And I value this expert opinion very much in this setting, and diazepam is a cheaper drug and it can be easily administered. And so if we are trying with paramedics, I think that is one of the best solutions. I quietly agree with that, and thank you very much for your feedback, sir.
I got the question now. We get patients who have been status like that is due to hypoxic brain. So when you approach these patients to sort of work in a different way or what's your treatment strategy, of course, when they have status or markers where that way, but in approach to those patients, they will be treatable. So they have different.
Yes, thank you very much for the questions. Yeah, that is even more challenging. The status epilepticus due to this hypoxic encephalopathy because unlike immediate mechanisms here, the epilepticus is almost always attacks. They are borderline traumatic patients most of the time, and hemodynamic compromise and other medical form factors will be there. If we find something that is treatable for this patient, apart from his hypoxic brain injury. So we have to actively treat that condition, infection and other compounding factors. But in the setting of hypoxic encephalopathy and this status epilepticus is always challenging, but still with the available anti-seizure medications and this condition. Yes.
Generally, I'm coming now talk about the power and everything is power involved. When it's the method that comes to the like very far, very well, and then we use the
Satish, you want to raise a question? Okay. Right. Okay, in absence of any other questions, let me thank Dr. Palya Gurugi by handing over the certificate of appreciation for doing this presentation.